Hey everyone, welcome back to another episode of Pediatrics 2.0. Very excited today because I get to talk again to Dr. Paul Offit, and he needs no introduction. And I want to save our time to specifically address a lot of questions that have come up now that we're in, late March. COVID cases are super low compared to when we spoke, in early January last. A lot has changed, and I think there's been a nice little lull and maybe a little bit of complacency towards COVID with all the other stuff happening in the world. But the first question that I had, and I polled the pediatrics or pediatricians COVID group, which has like 10,000 pediatricians in it. What can Dr. Offit shed light on us or explain for us? And there were a few common things that none of them will be a surprise to you. Boosters for adolescents. Can you update us on the status of should we be pushing strongly for adolescents to get boosters? Is that still something where it's unclear on the timing or necessity?
I think eventually we'll stop using the word booster. I think that this vaccine is a 3-dose vaccine for people over 65. I think this is a 3 or 4-dose vaccine, depending on the degree to which you're immune compromised, for people who are immune compromised. I think it for people who have multiple comorbidities, I think this is a 3-dose vaccine. I think for healthy young people, there is no evidence that you need a 3rd dose to increase your protection against serious illness, because that's the goal. The goal is protection against serious illness. There was just a paper that came out in New England Journal of Medicine looking at sort of the adolescent as well as the child, looking to see how long protection was holding up against serious illness, and it was holding up really well. So the reason being that to protect against serious illness, you need high frequencies of memory B and T cells, specifically T helper cells, as well as cytotoxic T cells. To protect against mild illness, you need high levels of neutralizing antibodies, which are always going to fade over time. So if the goal is protection against serious illness, I don't see the need for a 3rd dose in adolescents, otherwise healthy adolescents.
I think that helps to kind of remind people that those antibodies do wane, as one would expect with any infection, and the more distant that you get from either the immunization or from the infection itself. But those memory B and T cells persist and are what provide protection, it sounds like, from the severe illness, which is really what we're trying to address.
Yeah, I think what happened was when Omicron came in, Omicron was not just more contagious, it was more immune evasive. So even if you'd been vaccinated, you could still get a mild illness. And that was really what opened the door for that recommendation by the CDC for everybody over 12 to get a booster dose or 3rd dose. And I think what that will do is that'll increase your neutralizing antibodies for about 3 or 4 months, and then they'll come down, and then you're again susceptible to mild illness. I just don't think that's a reasonable public health strategy.
Right. I think everybody is quite tired of that. And honestly, sometimes when I see the news, I'm like, for adults, because I don't take care of adults, I'm like, how many boosters are we at now? Like, I can't even keep track of, if we're at 4 or 5 or, so I can completely understand that from the public health standpoint, we have to look at what's feasible and not just what keeps your neutralizing antibodies boosted, into eternity. How about vaccines in under 5? There was some exciting, hopefully, news from Moderna this week about their vaccines for the 6 and under crowd. Can you update us on what's going on in that age group and what we can expect in the coming weeks or months?
Well, presumably, these data will be submitted to the FDA, and then our committee, the FDA Vaccine Advisory Committee, will consider them. For right now, I know everything you know, which is basically what was in that press release. I mean, the press release stated that for the 6-month to 2-year-old child for Moderna's vaccine, which was given as a 25 microgram dose, the protective efficacy was 43.7%. That for the 2-year to 6-year-old, because this is right up to 6 years of age, it was 37.5%, which is actually very similar to the data that Pfizer had shown for protection against mild illness. I think there was no severe illness in this particular trial involving several thousand people. This was what you're doing is you're taking the ancestral strain, or you're taking a vaccine directed against that ancestral strain, the original Wuhan strain, and trying to protect against Omicron, because this is really Omicron time. So it's not hard to imagine why it is that you don't have great protective efficacy against mild illness. I suspect there's probably excellent protection against severe disease, but severe disease is rare enough in young children that you would have to do a really large trial to be able to show efficacy against severe disease. So the other thing that they stated was that they were considering a third dose. And you know that Pfizer, the Vaccine Advisory Committee, was supposed to meet on February 15th to discuss Pfizer's submission for what
Right.
clearly was a 3-dose vaccine, even though they'd only had data for 2 doses. So I think that's why that was eventually canceled, because you can't ask our committee to assume that a third dose would be more effective or to assume that a third dose would be as safe. And so I think that we no doubt likely would have voted no until we see the third dose data. And I really be curious if Moderna's sort of have their feet held to the fire to answer the question, is this a 2-dose vaccine or a 3-dose vaccine? Because this happened last year on February 26th when we were asked to consider Johnson & Johnson's vaccine. We were asked to consider it as a 1-dose vaccine, even though they were in the midst of a 30,000 person 2-dose trial. And so it eventually became a 2-dose vaccine. So that's the confusion, I think.
Do you foresee that so Pfizer's still working on their third dose. Moderna is preparing to submit. What do you think in terms of the time period that we could tell parents, if it's shown to be, effective or as effective as it's made out to be, that we can get doses in arms and legs of these younger children?
I would be surprised if we were considering this vaccine before May.
Okay, so before May. So we're talking summer or beyond for actually getting it into arms and legs. How about knowing that we have all this unvaccinated population in the under 5 crowd? With cases being so low right now, there's a lot of question of like, what should we be doing with those kids? Because a lot of the world has moved on, in the US at least, in terms of, the different strategies that we've been dealing with for the past 2 years. 2-year-old, 4-year-old in daycare, do you think that they at this moment need to be masked with their colleagues in daycare?
Here's what I would say. Here's the good news. The good news is natural infection also protects, and vaccination protects. If you look at this population in terms of people who've been naturally infected or vaccinated or both, we're probably at about 90% population immunity. That's good. We're also moving into spring and summer. And for what is at least appears to be primarily a winter pathogen. That's certainly true for human coronaviruses. We would expect that would also be true for this. And certainly the peaks are definitely in the winter months. So that's good. The only thing that's not good is that 90% is not equally distributed across the United States. I mean, there are some groups that are much higher or not as high, highly vaccinated. So I guess if there's not a high level of circulation of the virus in the community, I'm comfortable unmasking. I am for the children. Go back to school and unmask. I think this masking has been really difficult for children at some level. You don't get to see people's expressions. I think it's to some extent hard. So while I think it's important to mask, certainly when during peak season, I think we're way past peak season right now.
It makes sense to me too, because I mean, if we're going to tell people to mask, we should have some times when we don't have to mask, because otherwise people feel like it's going to be forever, and it's going to be forever. I'm not going to even do it when I need to do it. And instead we can say, okay, the case count is so low, it's almost hit, the bottom line. Why don't we take this time and enjoy this lull and return to closer to normal, both, at school and at home and with friends and all of those sorts of things. And hopefully, perfect timing with summer as well. Do you think that, pretend you're talking with a group of pediatricians from around the country, and they're asking, what should we be doing in our offices? Should we have our staff wearing masks? Should they be using N95s and gowns and gloves and goggles? I know that there are a lot of pediatricians that are still doing the full PPE for those visits, keeping kids in their cars, keeping them in separate waiting rooms for sick visits and all those things. Is now a time where practices can start to relax those things and return to normal? Because you're right, it is hard to read expressions, and you're having this, moment with this family, and sometimes they're dealing with mental health issues or all sorts of other things that are going on, and being able to be, face to face unmasked does make a difference in the way that you're able to connect and talk with them.
Yeah, I think, the definition of endemic as distinct from pandemic is whatever we define it to be. I mean, it's whatever the population says is true. So, I mean, it's not like this sort of clear, solid black line where you have X number of, say, deaths per million per day, and now we know it's endemic. It's whatever the
Right.
country decides is endemic. So I think at some level, I think this is going to be a hard pill to swallow, but we are going to have to get over this zero tolerance notion for this virus.
Sure.
Um, Both natural infection and immunization protect and appear to protect for a fairly long period of time for against serious illness, but neither are going to protect against mild illness for a long period of time. At some level, we are going to have to feel more comfortable with the fact that there's going to be mild illness with this disease in people who are vaccinated or have been previously naturally infected or both. And I don't know whether we can get there. We're so, locked in to this zero tolerance strategy that anybody who has a mild illness, has to quarantine and then not walk
Right.
out of the house unless they're masked, and it's certainly be asymptomatic. I just don't think over the long run that's going to be hard to maintain. We're going to at some level have to loosen up and be willing to watch people suffer a mild illness. I still would argue that for people who are vaccinated who suffer a mild illness, that long COVID is an extremely unlikely phenomenon. It's not zero, but it's extremely unlikely. And because if we're not going to be able to accept a mild illness, then we're talking about sort of frequent boosters, which is
Hmm.
going to drive us crazy. Or we're going to talk about constantly sort of masking and distancing, which will also drive us crazy. I mean, 2 years before before this pandemic hit, there were roughly 800,000 hospitalizations from influenza and about 60,000 deaths. Yeah, that's significant. We could have mass social distance, frankly, get 2 doses of vaccine during the season to keep your neutralizing antibodies high. And that would have dramatically lessened the incidence of that severe disease caused by that virus. But we don't do that. We grandfather that in. And I think we'll get there with this virus too. I just don't know what those numbers are and how long it's going to take.
Well, it makes sense because if we think about all the other things, like you've said in the past, when there were big flu surges, we weren't putting kids in masks at schools. We weren't wearing masks. Like I remember times in practice before the pandemic when if I had a really sick kid that I thought either had flu or strep, I'd have to like hunt around to find a mask just because I didn't really want to catch it and be sick for the weekend. And so we've tolerated those things before. And if we have a good vaccine that hopefully soon will be available for all comers, then we're at the point where, like you said, we do have to tolerate and live with the fact that people are going to have mild illnesses. The fact that, like with flu, some people are going to get hospitalized and have serious disease from it, but we can do things that are tolerable to make that less likely.
Or we could do what people do in other countries, which is mask the entire winter season and thus
Right.
decrease our ability to spread RSV, adeno, paraflu, and this virus and
Have
human
you
coronavirus.
seen on the same sort of line? This was actually a question from that pediatrics group too. Was how has masking or now unmasking impacted the other viral illnesses that typically plague winter or spring or summer? I mean, I know like last summer we had an RSV surge here that was like, there were no beds and it was June. And so is is there any things that we've learned about the way that masking or unmasking affects those viral surges that are non-COVID?
Well, certainly that first winter when we were masking, social distancing, and then, closing schools and shutting down businesses and restricting travel, we saw like no respiratory viruses in our
Right.
hospital. It was amazing. Flu, RSV, paraflu, human coronaviruses gone. So
Right.
that's all you have to do if you want to stop the spread of respiratory
Keep
viruses.
everybody separate.
Just nobody leaves the house. I mean,
Right.
that works. But assuming we're going to want to leave the house at some point, then we're going to be dealing with these. My sense is still those numbers are fairly low. When we were looking on the FDA Vaccine Advisory Committee, we pick the flu strains in the first week of March every year for a flu vaccine that will be available in September because it's a 6-month production cycle. And the flu activity was not I would say brisk. I mean, it was definitely less than what we'd been seeing previously, both here and in the world. So I think we still have an impact on flew by all this masking and social distancing. But it would be interesting to look at, say, countries that routinely do this, like, say, Japan, which often will mask, they'll mask every winter, and look at their incidence per population there as compared to here. I asked that question once, one of the advisory committee meetings, but people didn't have an answer.
I do think that one thing that will come away from this pandemic is okay, it would be really weird to go into church or a school and see somebody masked in 2018. Like you would, think they had cancer or something along those lines. And now I do feel like even in, I'm in Nebraska, which is a redder state. Um, People are more comfortable with their own wearing of masks or not wearing of masks, that I wouldn't be surprised in the coming winter, even if things are low like this, say December, January, that some people choose to wear masks and not get the flu, or not spread it to others, or be considerate in that way if they have a runny nose or cold.
Yeah, and be less comfortable, say, shaking hands, hugging. I think that you're right. I think we're going to be more reticent about how we physically interact with other people because that's the way we've been for the last couple of years.
Right. It takes a lot to unlearn these things that we've done and been forced to do. How about switching gears again, the BA2 subvariant? Is this something I know in Europe and other parts of the world, they're seeing surges? What is in store in the coming weeks or months for the United States with this subvariant?
Right. So today's March 25th. My understanding is we're at about 30% of the circulating strains are BA2, and I think it's even higher in New York State. What's different is, take a step back. So when the virus first raised its head, SARS-CoV-2 first raised its head in Wuhan, that was the ancestral strain, the Wu 2020 strain. That was not the strain that left China. The strain that left China was the first variant, the D614G variant, which swept through Europe, Asia, the United States, killed about 200,000 people here, which was replaced by the Alpha variant because it was more contagious, which was replaced by the Delta variant because it was more contagious, which was replaced by the Omicron variant because it was not so much more contagious as more immune evasive. What
Mm.
was amazing about Omicron and BA2 is that now you saw coronaviruses doing something that people didn't think it could do, which is basically drift. It had drifted far enough away that your protection against mild illness wasn't very good, even if you've been vaccinated. So now this virus had a chance to infect far more people because even if you were vaccinated at some level, you could be infected and get mild illness. That's BA2 also, which is also that immune evasive. Fortunately, both of those viruses, if you've been vaccinated, you still are going to be well protected against serious illness, but not as well protected against mild illness, which brings me back again to my statement a little while ago is, to what extent are we going to be comfortable having mild illness with these viruses? But I think BA2 will also ultimately take over. The thing that worries me about sort of getting back to sort of this frequent booster idea is that there are downsides to that. Especially if you're a male between 16 and 29 years of age, you are at low risk of myocarditis, but that is a real side effect of that vaccine, and it doesn't go away with additional doses. You still have a chance of having myocarditis. And the other thing is this phenomenon of original antigenic sin, where you sort of lock into that original exposure that you have. This is certainly true for influenza, which is where the term was actually born. I mean, as a child in the 1950s, I was probably infected with H1N1 as my first exposure to that virus, as a wild type virus. And I will always respond to all subsequent vaccines that I get as if I'm getting H1N1. That'll always be my best response. And you can see it with the HPV vaccines, actually. HPV-4 came out first. That was replaced by HPV-9. If you got HPV-4 and then 9, you actually respond much better to those first 4 strains you got than the other 5. You respond well enough to the other 5 to protect you, as compared to if you never got HPV-4, where you actually respond better to those 5 additional serotypes. So that's what original antigenic sin is. So there are downsides to frequent boosting. Because right now I think people think there is no downside. And there's
Right.
that little meme that you've probably seen with the Pfizer loyalty card where after the 8th boost you get a free pizza. So
Right.
that's actually not true, but yeah.
Do you think will there be in the next year an updated mRNA vaccine that takes into consideration the Omicron variant, or updates things so we're not starting with the ancestral strain as what we're being protected or immunized against?
Well, so it's a moving target. I mean, I think if we had an Omicron strain, then BA2 comes around, and if it's
Right.
not that, then it's going to be Omega or Sigma or Delta or whatever. But or Tau. Here's what I would say. I think the line is. I think we will need a variant-specific vaccine when it becomes clear that the current vaccines, basically the vaccine against the ancestral strain, no longer protects you against serious illness. If that's
Yeah.
true, then we need a variant-specific vaccine, and we're starting all over again. If that's
Right.
true, you're getting that primary series all over again.
at least at that point, we'll already have all, it seems like from my very kindergarten level understanding of the mRNA vaccines, that it will be much easier to, copy paste or copy, cut, delete, splice back together to update that than starting from zero once again with developing the vaccine.
Yeah, and maybe we can get this sort of pan-sarbecovirus vaccine, which would prevent you from having illness against all of these viruses like SARS-1 or MERS or now SARS-CoV-2. I mean, that's in the works, much more easily said than done. There's certainly enough money to try and find
Mm.
that. We'll see whether we can find. But again, I trained in the 1980s in a flu lab at the Wistar Institute, and Walter Gerhardt was the head of that lab, and he was working on a universal flu vaccine. This was about 40 years ago.
Mm.
Much easier said than done.
What about long COVID in children and adolescents? Do we have any more information about the prevalence of it or the severity of it, or if there's any good treatments? What's the update on long COVID in the child and adolescent age group?
Yeah, well, Dr. Jeffrey Gerber at our hospital, who's in our Division of Infectious Diseases, believes that the long COVID in children is to some extent overstated, that
Mm.
we really need much better studies to look at this. There's a certain suggestibility to this. And so compare, say, children who've gotten flu as compared to children who've gotten this virus and ask them the same questions 4 weeks later, 6 weeks later, 8 weeks later in terms of fatigues, headaches, joint pain,
Right.
muscle ache. Ask them those questions. He thinks it's overcalled. And the long COVID is, I think, in some ways driving our fear of mild illness. But I still would
Sure.
argue that if you've been vaccinated and you have a mild illness, your chance of long COVID is very low. And we just need better. Long COVID is more than one thing. Certainly, this
Sure.
virus is unique among the respiratory viruses in that it can cause you to make an immune response to your own blood vessels and vasculitis. That's what this multi-system inflammatory disease of children is. It's essentially a vasculitis, a post-infectious inflammatory disease. And so that I'm sure is part of the reason that you have long COVID, because all organ systems have a blood supply, therefore all organ
Right.
systems are at risk. So I think that's part of it. But I think that I'd like to tease out that from what I think is probably at some level a psychological component to this illness and see what we're really dealing with.
Mm. How about how about something other than COVID? What if there was no COVID, what would be at the top of your list right now for things in the public health sphere in pediatric infectious disease that you would be going on talk shows talking about?
I'm trying to imagine that. I think there was no COVID. I think I'm ready to retire is the way I feel.
Is
Um,
is there anything interesting in the pediatric infectious disease literature that's getting missed right now because of the COVID centric
well,
focus?
right. So great. I think we're very close to a respiratory syncytial virus vaccine. I mean, this is a virus that still kills 5,000, babies a year. And I think we're very close to that, and probably as a maternal vaccine. I think
Mm.
one thing that's interesting about the mRNA technology is, as distinct from other technologies when they're introduced, is you have an enormous safety platform for pregnant women. That didn't exist before. So I
Right.
mean, could this be used then for Group B strep vaccine, meningococcal vaccine? RSV vaccine. So we'll see how that plays out. But that's to me the most interesting, and also for mRNA, which I think has implications for gene replacement and for cancer therapies. It'll be interesting to see how this plays out. It's honestly, I think it's the greatest scientific achievement in my lifetime, and my lifetime includes the development of the polio vaccine.
Wow.
It's remarkable how it all came together. And when we were the FDA Vaccine Advisory Committee was asked to recommend this vaccine, say in December 10th of 2020, when the Pfizer first submitted, and then a week later with Moderna. You knew, because it's always historically true, that when a vaccine is tested in thousands of people or tens of thousands of people, you're going to find things out when it's in tens of millions of people that you didn't know about yet. So you
Right.
kept waiting for that other shoe to drop. The only question was, how bad was this adverse event going to be, and how rare? And for the mRNA vaccines, we were surprised, obviously, by myocarditis, but again, rare and generally transient and self-resolving. And then for the vectored virus vaccines, this thrombosis with thrombocytopenia syndrome, also very rare, but much more serious and occasionally fatal.
Right. Well, and I mean, with this mRNA platform, we've had what, 4 billion doses of vaccine given, something like that. So it's been the fastest trial ever to say, is this safe and what's going to fall out? That that it speeds up the production cycle, I'm sure, for all the other things that you could potentially do with that to have that kind of safety data captured already.
No, it's amazing. It's sort of the largest vaccine effort in history. Amazing.
Well, it's been a pleasure to talk, Dr. Offit. And, I hope your dance card stays rather empty for a while. And I hope I don't reach out to have you on again for a while, because we're continuing this lull, and maybe we can touch base after the summer or something like that.
That would be great. Thanks, Phil. I appreciate it.
Thanks a lot.